So hi everyone and welcome to this new week, new topic, and in this particular week we are going to deal with the topic of thorax. So again I'm returning back to our old pattern, meaning by not just 5 minutes but it will take around 15-20 minutes to discuss some more MCQs, right? Because anatomy is a huge subject and there are so many topics, so we try to cover as many topics as possible. So let's start the session, and here's the first MCQ of the thorax. The question goes like, a 56-year-old construction worker comes to his family physician complaining of pain in his neck and shoulder, okay, numbness and tingling in the right fingers, and weak grip in his right hand. So there is pain, there is numbness, tingling, there is also weak grip. So both motor and sensory is involved. His symptoms are exacerbated by carrying heavy objects on his right shoulder. So there is some correlation which he has judged. A given plain X-ray indicates the presence of a right cervical rib. Very good. In close approximation to the proximal part of first rib. Okay, so right side. Now I may put an arrow over here to show you what they are referring to. This is the point where they are saying about the right sided cervical rib above the obviously the first rib. Now, given the signs symptoms of this patient, what structure is most likely impinged by the cervical rib? So, they have already given the diagnosis, it's a case of cervical rib. Now, they are asking that the cervical rib is impinging on which structure, so that there is sensory and motor and also weak grip and pain, all of that. So, there is pain, there is sensory and motor involvement. Options over here are common carotid artery, right side, brachiocephalic trunk, right subclavian artery and vertebral artery. So, all the four options are of artery. In artery, you can say that, okay, the symptom of pain can be related to the constriction of the artery. We all know the 5 P's which we learn in pathology, pulselessness, pallor and pain and paresthesia, all that. So, they are asking that the right side cervical rib will be compressing which particular artery. Answer over here would be what? Answer over here would be straightforward question, the right sided subclavian artery. Okay, so answer will be our option number C. Let us see how. So here's a image of a thoracic cage over here, right? It's a thoracic cage. Okay, let me point out that this is the probable location where we have the heart over here, right? And behind the manubrium, this is where we have the arch of aorta. Okay, this is where we will have the brachiocephalic trunk. If I put more dots over here, this is where we have the brachiocephalic trunk on the right side. What actually happens is the right carotid artery will go upward because it is going to the neck. So this is the right common carotid artery. While the right subclavian artery is going to go below the clavicle and over the first rib. This is the location. This will be the location of which artery? This is the location of the right subclavian artery. Right subclavian artery. Now, as soon as this right subclavian crosses the first rib, it becomes which artery? What is this artery over here? This artery over here, it's a continuation of subclavian, but now it is known as axillary artery. Now, where is the cervical rib? Cervical rib is actually over the first rib, so this is the probable location of cervical rib. Now, due to the presence of cervical rib, what happened actually is, initially the right subclavian artery was going like this, right? Now, what happened is that after the presence of cervical rib has come down like this. Now the subclavian artery will be going like this. So there will be a kink, there will be compression or constriction of the right subclavian artery along with the compression of another structure which is the C8 and T1, that is the lower trunk of brachial plexus. So complete knowledge over here is that it is not only the compression of the right subclavian artery, that is obviously there the answer, but apart from this there is also going to be the lower trunk of brachial plexus also will be compressed. Why? Because they are now taking a more acute route, more longer route, they are arching more over the cervical rib. So this lower trunk of brachial plexus is C8 and T1, and therefore if you see in the question you have motor and sensory findings in the hand region, that is the region of the ulnar nerve, that is the region of the ulnar nerve as well, right? Now let me show you one more image to all, just to supplement what all we have learned over here. This is the subclavian artery over here, and this is the jumping over the first rib. So here you have what? You have the first rib going down like this. Now due to the presence of the cervical rib which could come like this subclavian artery now will have to go like this. That is why. Okay. So going back to the question, I hope the question is very clear. The question was about the cervical rib, and remember that cervical rib as a finding is very common. Okay, as a finding it's quite common, and 1.5 to 1% of the population has cervical rib. Okay, so remember that. So cervical rib, the take home point, subclavian artery and lower truncobrachial plexus. Normally these are compressed. Let's go to the next one. 68-year-old complains of swelling in the skin of the back of the chest. So there's swelling in the skin of the back of the chest. Fine. He had noticed it for the last 3 years and was concerned because it was rapidly enlarging. On examination, the hard lump was found in the skin of the right scapula line, opposite the 7th thoracic vertebrae. So opposite the 7th thoracic, opposite the T7, right? T7 vertebrae. Posteriorly, they had a swelling which was enlarging in the last 3 years. A biopsy revealed that the lump was malignant, okay, because of the rapid increase in the size of the tumor. Which of the following lymph nodes were examined for metastasis? See, they have given us what? They have given us the location of the swelling. It is a malignancy. Now they are saying that swelling was enlarging. Now they are saying which lymph nodes. So basically what we have to see is that this, from this location, which lymph nodes are involved. And location is where? Location is at the skin, right? It's quite superficial. So location is at the skin, back of chest, around the T7. If you look at the general body, let me show you an image over here. General body, the superficial drainage, the superficial lymphatic drainage. If you take the watershed line over here, this watershed is actually referring to the around the umbilicus plane, right? It goes over the iliac crest posteriorly as well. What happens is everything superior or above the level of umbilicus anteriorly will drain into the anterior axillary lymph node. But where was the swelling in this question? Posteriorly. So everything superior to this watershed line posteriorly will drain into posterior axillary lymph node. Actually, this is the answer for the question. While if the swelling or if the lump or ulcer, whatever it is below the watershed line anteriorly, then they will drain where? Anteriorly they will drain to superficial inguinal lymph node. Same goes for posteriorly also, they will drain again to superficial inguinal lymph node. So below the watershed line, superficial involvement always will go to the superficial inguinal lymph nodes. While above the watershed line, anteriorly anterior axillary and posteriorly posterior axillary. Now if we come to the options, I hope we will have certainly option number C over here is waiting for us to answer. The topic is the lymphatic drainage of the body, very important. Also remember over here about the thoracic duct, that it drains all the parts of the body internally mainly, except the right half of the body above the level of diaphragm. Above the level of diaphragm, the right half of the body, that is right head neck, right upper limb, right half of chest, it drains into the right lymphatic duct. While above the diaphragm, left half of the body, and below the diaphragm, the entire body, it drains via the thoracic duct. And where does the thoracic duct finally drain into? Into the junction of the left subclavian and left brachiocephalic or left interjugular vein, or we can say left jugulo-subclavian junction. Right, so remember that too. Okay, moving on to the next one. Here's the next question, and the clinical applied question. Let's see this question. The question asks us that a 52-year-old lady was admitted to the hospital with a diagnosis of right-sided pleurisy with pneumonia. It was decided to remove sample of the pleural fluid from her pleural cavity. So, 52-year-old lady had some pleurisy with the pneumonia, and they took a sample just to check what was that fluid about, transient exudate or TB, whatever diagnosis they want to make. The resident inserted the needle close to the lower border of the 8th rib. So, needle close to the lower border of the 8th rib in the anterior axillary line. The next morning, he was surprised to hear that the patient had complained of altered skin sensation extending from the point where the needle was inserted downward and forward to the midline of the abdominal wall above the umbilicus. So, now there is a problem. The resident is also scared that he will be scolded harder, right? So, now the patient is complaining that there is some altered skin sensation from where the needle was entered actually, and towards around the for downward forward in midline. The altered skin sensation in this patient after the needle thoracostomy could be explained by what? So, how is this to be explained, right, anatomically? Options are: needle was inserted too low down in the intercostal space, needle was inserted too close to the lower border of the 8th rib and damaged the 8th intercostal nerve. Actually, option number B. That's a straightforward question over here. This is the answer. Now, if you look at the anatomy over here, then at the lower border of the rib, the typical rib, we have the intercostal grooves, and in that groove, we have the intercostal nerve and vessels. So if you insert a needle close to the lower border of any atypical rib, there are chances that you might damage the intercostal nerve or intercostal vessels. Here, I guess the nerve was damaged, and therefore the patient later on had an altered sensation. Okay, let me show the image over here. So imagine this is your rib number 1, that is rib number 2, and imagine the needle entered somewhat around over here, lower border of the rib 1. What actually happens is that these structures over here, the intercostal vein, artery and nerve, and do remember their arrangement as well. Vein, artery and nerve, we can remember it by the mnemonic VAN, V-A-N. So when the needle entered over here, it might have taken the lower line or the inferior line nerve over here, might have impinged or damaged this nerve, leading to the altered distance sensation. That is the whole point over here. Answer is typical option number B. So it's a lesson that never enter at the lower border of the rib. The way to enter, either enter at the upper border of the rib or somewhere at the middle, but never enter at the lower border of the rib if you have to do a drainage. There might be a case when you can enter the lower border of the rib, when you have to specifically block this nerve, when you have to do an intercostal nerve block. When you do a nerve block, then you enter the lower border and you spray down all the anesthesia, the xylocaine solution over there. Then obviously you have to go at the lower part of the rib to make this nerve non-functional for some period of time, like in a rib fractures or any other thing, right? But not for drainage. No. Let's see this question. A 6-year-old boy is brought to the physician by his mother because of what? Because of a 3-month history of episodic chest pain and shortness of breath on exertion. Okay, 6-year-old boy has a 3-month history of chest pain and shortness of breath. He is at 99th percentile for height, good height, but 40th percentile for the weight. Weight is on the lower side. Examination shows a high arched palate. Now here are findings. Examination shows what? A high arched palate, a long and slender upper extremities, remember pathology as well, and elbows and knees that can be hyperextended, right? Cardiac examination shows a grade 2/6 late systolic crescendo murmur with a mid systolic click. Over which of the following labeled areas is the murmur most likely to be heard best? Very good question, aligned question. Now see what has actually happened over here is 6-year-old boy with all these findings having a murmur. All these findings are referring to some disorder, that is the Marfan, probably a Marfan syndrome. Marfan syndrome present with this sort of murmur, basically for MVP, mitral valve prolapse. Now we have different areas given in this particular question, like A, B, C, D, E, F, G, H. Where would you hear the mitral valve prolapse? You will obviously probably hear it around the mitral area. Where is the mitral area? It is at the area of apex. Where is the apex area? Option number F over here. Option number F is this D over here. What are the different areas? Let us see the different areas as well. This G is going to the axilla, right? This A is around the region of the carotid. Okay, we hear the carotid roots whenever you have a new case of hypertension. Try to hear, you take the stethoscope, try to hear the carotid roots as well. The B area over here is the aortic area, right? The C is the pulmonary area. The E is the tricuspid area. F already told you is the mitral area. D is the left external border. G is axillary. Areas as well over here, right? So we should be knowing these areas as well over here, right? So it's a case of mitral valve prolapse. Okay, now coming to the next question over here. A 54-year-old, listen to this question very carefully, it's quite a basic question. 54-year-old presents with the loss of sympathetic innervation to the left side of his head, characteristic of Horner syndrome. Okay. MRI revealed a left-sided pulmonary sulcus tumor with a location approximated by the black dot to which the arrow is pointing. You can see this over here, this black dot towards where the arrow is pointing. What structure is most likely compromised by the tumor? So, in this question, they are already saying that the patient had a left-sided Horner syndrome. Horner syndrome, we all know, it is a sympathetic denervation, right? Sympathetic system to the left side of the head is denervated. MRI was done and they showed, okay, there is a tumor over here. This tumor might be the reason for the Horner syndrome. They are asking, what structure is exactly impinged or compressed or compromised by the tumor, leading to the left-sided Horner syndrome. So, options over here are cervical anterior roots, thoracic posterior, thoracic anterior roots, and thoracic gray rami communicantis. This we need to know the basics. The basic over here is about the basics of sympathetic supply, right? We'll come to this image in a while. First, understand what happens actually. See, we have this whole, what we can say, the spinal cord over here. Now, it is from T1 to L2 that we have the outflow part of the sympathetic. Right? So, sympathetic come from T1 to L2. Now, what extra happens is that over here we have what? We have a paravertebral chain, okay, or paravertebral ganglia. These are all the sympathetic ganglia. What actually happens is that these pre-sympathetic nerves, right, they anastomose or they synapse over here, and from here the post-ganglionic nerves will come out. Right, so this red color, imagine them to be the post-ganglionic, these black color are the pre-ganglionic. So they come out from T1 to L2. So they will distribute from T1 to L2. Some of them will obviously go down and some of them will obviously go up. The nerves which are going up are basically T1 to around T3 that are going to go up. Why? Because they have to supply the head and neck region. Right, that is what the question is. Now, the sympathetic is basically a motor output. So, if you look at this cross section of the spinal cord, what you see over here is you have the ventral nerve root, you have a dorsal nerve root. Now, sympathetic come out from the lateral gray horn and they mainly come out through the ventral nerve root. So, sympathetic will be lying over here. Then they will actually synapse where? They will synapse in the sympathetic ganglia over here, and then obviously you have the both ramis and then they will go up and down. You have the ganglia in the cervical region as well. So, the nerves which have to go to the head and neck, they need not be synapsing there at the level of thoracic ganglia. They will first ascend up. Which will ascend up? The anterior root, the thoracic, upper thoracic anterior root is going to ascend up. Then it is going to synapse around this, which we can say as the cervical sympathetic ganglia, and then from there they will go to the head and neck. So it is basically the anterior or the ventral thoracic roots that is carrying the sympathetics to the head and neck. Now, if we come back to the options over here, cervical anterior roots, they don't have sympathetics, because sympathetics they come from the thoracic. Thoracic posterior roots, as I told you, posterior roots are basically the dorsal, which are basically sensory, they don't have motor or the sympathetic. Yes, thoracic anterior roots are the one which are going to carry or which are going to have the sympathetic, the preganglion sympathetic, which are going to ascend up, they are going to synapse in the cervical sympathetic ganglia, then they will reach the head and neck. It is the thoracic anterior roots. While if you look at the option number D, thoracic gray rami communicantis, now what actually happens is that we have two rami communicantis, you can see in the image as well, we have a gray and we have a white rami communicantis. So where also it must be written about the white rami, but understand that the gray rami communicantis is the post-ganglionic, right? White rami communicantis, we have white rami communicantis, that is the pre-ganglionic. So why is not D the answer? The reason is that the gray rami communicantis of thoracic part has already synapsed in the ganglia at the thoracic level. So it is going to supply the region of the thoracic wall only. Getting a point? So this gray rami communicantis, it has already synapsed in the thoracic ganglia. It has not ascended up to go to the cervical ganglia. So it will reach and supply the thoracic wall only, where we are discussing about the Horner syndrome. Therefore, answer will be option number C. They will go up and they will ascend and they will send synapse. Right? So that is why option number C is the answer. Beautiful question, understand. Okay, so guys, that was all for today. I hope you guys enjoyed. Again, we are going to meet tomorrow with some other MCQs, other topics on the thorax. Do leave a comment if you have anything to say, or if you liked it, do share and subscribe. That's all the best. Keep learning, keep growing, keep focus.